Hi everyone, thanks for joining us. I'm going to start out by talking a little bit about the diagnosis and imaging that goes along with primary hyperparathyroidism. So first, some background, which probably most of you don't need, but we'll just go through a little bit of it. Primary hyperparathyroidism is caused when one or more of the parathyroid glands becomes overactive. Most of the time this is just one single gland, but 20% of the time it can be more than one gland. This leads to a variety of biochemical and bone deficiencies, including osteoporosis. It can cause kidney stones, and then a whole host of other symptoms, many of which can be confused for other diseases. It predominantly affects females, and the only treatment is surgery. So how do we diagnose this disease? It's primarily a lab diagnosis or based on blood work. Mainly elevated calcium and an elevated PTH, but then there are some variations in this which we call mild disease. So you could have the disease with a normal calcium, or you could have a normal PTH, and some patients do have both. Often it's confused with secondary causes of hyperparathyroidism, the most common ones being kidney failure or low vitamin D levels. This can become quite complex, and often it's necessary to repeat the labs or to do more advanced testing to help clarify the diagnosis. And that's what I'm going to talk about here, is that often we do get additional testing. Most commonly, this is sometimes urine testing for urine calcium and urine creatinine. Often we need to measure vitamin D to make sure that it's not a secondary cause of hyperparathyroidism. There are a variety of other more complex blood work that needs to be done, including PTH-related peptide if you're not sure that it's primary hyperparathyroidism. Sometimes this disease is caused by genetic disorder, and so genetic testing becomes necessary for the patient and possibly the patient's family. Again, kidney function is often measured in order to make sure that it's not one of the secondary problems. And then we often try to do more provocative testing by doing a trial of either calcium and or vitamin D supplementation and then repeating some of these labs. So it can be quite complex. Of course, it takes many patients a long time before the diagnosis is officially made. Labs are rechecked or monitored, and in some cases PTH levels aren't ever checked at all, and those are the saddest cases that we encounter. Patients then can spend years suffering, or they're told that it's something else. So they're told that it's all in their head, or that they just have depression or anxiety or a whole host of other diseases that often mimic this disease. Patients often come saying they just have no ambition or no energy. And so it's attributed to other causes, and many of which are psychiatric causes, like we said. So I'm going to move on a little bit to imaging, because this often is a cause for one of the delays in getting definitively treated. So the diagnosis, as we said, is primarily based on labs or blood work, and it's not really based on the imaging. The severity of the labs often doesn't correlate with how bad the patient feels. So you could have mild disease but still have very bad symptoms and a very bad quality of life. And then whether or not your imaging is positive doesn't mean that you don't have the disease. So negative imaging doesn't mean that you don't have the disease. Along with that then, even if you have positive imaging, there's reasons that the imaging could be wrong or incorrect. So imaging is mostly used for planning surgery, but not for making the diagnosis. So we see it as a starting point. There's a lot of different options for imaging. Here at UW, we just start with probably the most inexpensive and least invasive method, ultrasound. Ultrasound doesn't involve any radiation. We can do it right in the office. We often do utilize other means for imaging, things like sestamibi scans. Sestamibi scans often, though, lack finer detail that we can see with either ultrasound or CT scans, which are more invasive. They also involve radiation and contrast, but they do provide that fine level of detail. And so we do use CT scans. Often they're used for reoperative surgery when localization is key. None of these, though, are 100% accurate, and all require an expert to interpret them. Often there's confusion about whether it's an upper gland or a lower gland, and so you really need an expert that's used to the anatomy, used to the embryology or the development of where the parathyroids come from, and then putting it together with the patient history. There's a lot of different testing that one can get for hyperparathyroidism, and some of it is more advanced or invasive. There's lots of options, so MRIs, there's a variety of different scintigraphy or sestamibi type scans, including Sept sestamibi scans, and then more invasive things like venous sampling or angiography. One thing we use, especially in reoperative cases, is we actually can do a very fine needle biopsy of a suspected parathyroid and then measure PTH from that. So what if all of the imaging is negative? There's a couple of questions that I often ask myself when this happens. First is, what is the probability of having a single gland? A lot of the imaging tests that are ordered are all geared towards finding a single gland. So if I think based on the labs that the patient does not have single gland disease, but rather has multi-gland disease, then getting more imaging really won't be that helpful. Is this the first operation or is it a reoperation? I think localization and sometimes dual localization is more important when we're talking about a second operation, because there's already scar tissue there and we need to have a very targeted and safe approach. Is the imaging really negative? So who's saying it's negative? Is that person really familiar with the anatomy and development of parathyroid glands like I was talking about earlier? And again, this all requires expert judgment and experience and really familiarity with parathyroid disease. It's often said that the best localization study is to locate an expert endocrine surgeon. And I think that really holds true for all of the things that we've been talking about so far. So I'd like to spend a little bit of time telling you about some of our research here. And this really came about because of all the patients that we see with parathyroid disease that have suffered for a long time. So patients spend a long time suffering before the diagnosis is officially made. Labs often get rechecked or monitored for many years. These labs can be subtle or quote-unquote normal. Even when we as experts look at it, we realize, no, these really were abnormal all along or trending towards being abnormal. And patients do improve their quality of life after getting surgery. We see this day in and day out. So how can we do better? How can we improve on this? We wanted to know if there's some technology that we can help physicians across the whole country improve their diagnosis or recognition of this disease. And so our goal was to develop a computer program that could diagnose hyperparathyroidism automatically. So take labs that are in the electronic medical records and alert the doctor that the patient has the disease. And that's exactly what we did. We made a very accurate computer model. It was over 95% accurate. And it assists non-specialists to recognize this disease. And it can even help experts for the borderline or mild cases. We think that it can really improve the diagnosis of this vastly underdiagnosed disease and enable more patients to receive treatment and decrease the amount of time that people spend suffering. So here's where we are now. So a patient gets blood drawn. Maybe it shows maybe even an early or mild form of the disease, but then it goes unrecognized and the patient spends years, maybe even decades, and during that time their bones are getting weaker, they can develop osteoporosis, Some patients may develop things like kidney stones, as well as a whole host of other symptoms. And then finally, they get their blood monitored or checked again. And this time, the disease is more obvious, or for whatever reason, it gets recognized and the patient gets diagnosed. But here's my vision for the future. So in the future, patient gets their blood drawn, and maybe it shows an early or mild form of the disease. And now the computer automatically recognizes the disease, tells the doctor, hey, this patient has hyperparathyroidism, and they can go on to get surgery much more quickly. We know that getting surgery then improves their quality of life and hopefully strengthens their bones. So with that, I'm going to turn it over to Dr. Pitt, who will speak next. Thank you.
Hi, thank you all for coming. I hope you can tolerate. I have a little bit of a cold, and so my voice may sound a little bit hoarse at times. So I'm going to focus on the actual surgery for parathyroid disease and talk a little bit about where we've come in the last 15 to 20 years. This is just a slide showing you, that most patients, as I'm sure you all know, have an adenoma or a single gland disease. However, we do see 2-gland disease, 4-gland disease, and very, very rarely is there 3-gland disease. So in the past, surgery involved a big incision. People visualized everything. Patients had a very big scar. And there was some question on how satisfied patients were with their outcomes, mostly related to the surgical procedure itself. In addition, identification of all 4 parathyroids was common, and this was confirmed with frozen section, which created a time delay. There wasn't frozen section available widely at every hospital and required a lot of effort from the pathologists. And then, as I said, we tended to look at all 4 parathyroids and confirm them visually, but this is also subjective and it depends a lot on surgeon experience and the volume, which is something that throughout, I think, our discussion this evening, we will discuss the importance of. And so this is an example of the size of an incision over here on the right. It was a long neck incision that we called a collar incision that usually was about 8 centimeters long. And there was a significant amount of dissection performed in the neck. And so over time, we've asked ourselves, can we modernize parathyroid surgery and improve this? Dr. Schneider just spoke a little bit on better imaging, and I'll touch on that, as well as I'll speak a little bit about technology related to drawing parathyroid hormone levels in the operating room, using the radio-guided probe, and then performing more of a focused approach. And there's been some debate back and forth, especially recently, on whether or not a focused approach is the best or whether we should always be looking at all 4 parathyroids. However, over time, we've been able to develop smaller incisions, which are associated with less pain and promote patients going home the same day. So to start with better imaging, Dr. Schneider touched on, Sept scans are something that we've used for a while. Most recently, the 4D CT scans are sort of one of the most kind of up-to-date imaging techniques. And you can see here, this is a parathyroid, and depending upon the phase of the scan, the parathyroid has a specific characteristic in terms of how the contrast washes out and helps us identify it per se from the vessels in the neck. In addition, surgeon-performed ultrasound has become very popular in the past 10 years. And this is really because it's almost like an extension of our physical exam. The radiologist, may intermittently do ultrasounds for to localize parathyroids, but if this is something that we're doing, all the time, every week, it really kind of helps us. We know exactly where they are because we're doing the surgeries or where they tend to be. And using combinations of these techniques has really been something that's helped us localize parathyroids prior to surgery. These are just the titles of some studies we've done here that have helped show the advantages of imaging to help localize the parathyroids and perform a minimally invasive focused approach to parathyroidectomy. One of the things that Dr. Schneider touched on was using was the impact of surgeon interpretation versus radiology interpretation in sestamibi imaging. So in terms of moving forward, I want to speak a little bit about technology. So the first thing that really came on the forefront was intraoperative parathyroid hormone testing. And this here is just an image of what the lab machine looks like that produces our results. And so this helps us when we are in the operating room and there's just a single adenoma or a single gland that is enlarged. When we take it out, we can draw the parathyroid hormone levels either prior to surgery or just before removal of the parathyroid, and we'll get a baseline level. At 5, 10, and 15 minutes, this level should drop below 50%, and this line here is to represent 50% of 140. Our starting value would be 70. This is also the normal. And so we want to see both two things, that it's dropping at least 50%, but also into the normal range. And so in this particular case, this would confirm a cure. What happens in patients who have hyperplasia or two adenomas is that when we draw the levels, they drop a little bit, but then they plateau and they never reach this sort of 50% or normal point. We then perform a bilateral exploration, and you can find a second adenoma or perhaps hyperplasia, repeat the labs, and they will drop. And so the implementation overall of intraoperative parathyroid hormone testing nationally has taken us from cure rates of approximately 90% to nearly 100%. And we have really here at the University of Wisconsin been at the forefront of showing the efficacy of intraoperative parathyroid hormone testing and its effect on our progress. These studies are some other studies we have performed in terms of examining intraoperative parathyroid hormone testing and its value in multiple different types of patients, those with multi-gland disease or hyperplasia, even those with hyperparathyroidism related to their renal disease. Another technology that we have used is the radio-guided probe, and this helps with intraoperative localization as opposed to the preoperative studies, which are also can be a sestamibi study. And the overall background idea is the same in that the parathyroids take up the sestamibi more so than other surrounding tissue, and we can use the probe to help confirm that the parathyroids are in fact parathyroids. And so how does this work? So the parathyroids, I don't know if you remember back to your biology classes, but have more mitochondria in them, and they are really the sort of the powerhouses of your cells. And the mitochondria take up and retain the sestamibi. And so since parathyroids have more mitochondria, they will take up and retain the sestamibi more so than the rest of the tissue around it. You can then use the handheld probe to locate the parathyroid, and then you can test it after it has been removed. And this is what we call sort of in vivo and ex vivo background counting. But to start surgery, we take a count and just see what's the background of the thyroid. Once the parathyroid has removed, we can place it on the end of a probe. And if the ex vivo count, which just means it's out of the neck, is more than 20% of the background count, then we know that it's parathyroid tissue. We've showed this over time with multiple studies. And this doesn't help as much in localization because sometimes the background can be a lot, though it will often send you in the right direction. But the thing that it definitely does is make the need for frozen section no longer necessary. So these are also, again, several studies that have been done by our group that, sorry, is this showing up there? Several studies by our group where we have looked at the efficacy of radio-guided parathyroidectomy. And then to move on, the last thing I sort of wanted to touch on was the focused approach. And this is just using a much smaller incision. We localize the parathyroid. We can do this using the probe. Once the parathyroid is removed, we can confirm that this is parathyroid tissue and not have to send it off to get a frozen section. And ultimately, the outcome is much more cosmetically pleasing. I did not put in here the use of the intraoperative parathyroid hormone assay, but that helps us. This does not mean that we think that all patients need to get a focused approach, or that a bilateral neck exploration isn't necessarily the first step. For certain patients, it may be that a bilateral neck exploration is the most sort of appropriate approach initially. And I think one of the difficulties in both diagnosing and treating parathyroid disease is that every patient is a little bit different, and so it's hard to say, oh, focused approaches for everybody or bilateral approaches for everybody. And so we've, over time, gone from incisions that I initially showed you to something like this, which is a very well-healed incision that we try to hide in the skin folds of the neck. One of the things that has also happened is even in patients who are getting bilateral neck exploration these days, the incision size has gone from here down to here, and that's just with general improvement in the technique of surgery. And so what has become of modern parathyroid surgery? So we've been able to use better imaging to localize parathyroids. We've been able to deploy radio-guided techniques to help us both identify the parathyroid, but more so confirm that it's actually parathyroid tissue. We've been able to develop intraoperative parathyroid hormone testing and really help us in those patients who are appropriate for focused approach. I think this has improved patient outcomes in terms of quality of life, length of stay, and it can often be less costly as well. And so in the future, where do we want to go? Dr. Schneider talked about developing ways that we can improve diagnosis. I think another way is training more surgeons who are very well adept to these techniques so that there are more options for patients. So this just is a summary of some of the adjuncts that we've done and studies that we've done. And this here is just showing that we have focused on training here at University of Wisconsin, and we've developed a fellowship program. In addition, we have a gloves on program which allows surgeons from around the state to come and learn our cutting edge technology and innovative techniques in endocrine surgery. Over the past 15 years, the number of surgeries that we have done has gone from less than 50 to well over 300 in 2014 and continues to climb. And this sort of volume is very important when searching for a surgeon, because we know that there are definite relationships between surgeon volume and outcomes. So I think to summarize this portion, what do we need to consider before surgery? So is a diagnosis right? Because surgery is the only cure for primary hyperparathyroidism. And then I think when searching for your surgeon, you should be looking at their training, what they plan on doing and what their approach is. Does that make sense for you as an individual? What is the volume that they perform and their center performs, and what is their overall experience, and then what outcomes have they shown over time?
All right, hi, I'm Rebecca Sippel. I'm the Chief of Endocrine Surgery here, and what I'm going to talk about a little bit is the sort of the next step, what happens after surgery. I think a lot of the questions that we got forwarded were sort of just patients wondering what is it that I should expect after surgery. So a few things I wanted to talk about is some of the complications or problems that can happen. And hypocalcemia after surgery or symptomatic low calcium levels is probably the most common problem that patients may encounter after surgery. And that probably occurs in up to 20 to 30% of patients. This is a problem that we see a lot in patients who are undergoing thyroid surgery, and we've developed a lot of expertise in how to manage it in that population. I think it becomes a little bit trickier in patients with hyperparathyroidism. But I'm going to talk a little bit about what are some of the symptoms that we should look out for, who is really at highest risk for this complication, and then how can we treat it and how can we prevent it. So what are some of the symptoms? The most common symptoms of low calcium is that patients will get paresthesias in their hands, feet, or face. This may feel like your hands are falling asleep or that there's some numbness or tingling in your face or lips. Occasionally patients will have muscle tightness or cramping or just feel like they can't grasp things very well. And it can affect personality too. It can just make you more irritable or just anxious. Who is at highest risk for this complication? I would say probably the patients that we worry most about this are those patients who have fairly significant bone disease or have had a significant degree of bone loss. So many patients have had a bone density scan, and the more negative that number is, the more concerned we are that you may have kind of what we call hungry bones, where your body is just deprived of calcium and be higher at risk for having trouble with low calcium. We also see that patients that have really large parathyroid adenomas are much more prone to have trouble with low calcium afterwards. Also, patients who have significant vitamin D deficiency. Vitamin D deficiency is really common in patients with hyperparathyroidism. It's really part of the disease process, and almost everybody has this. But if it's a really low vitamin D level, that can just make it that much harder to treat the low calcium should it happen after surgery. So how do we treat it? The most effective way for us to treat hypocalcemia after surgery is that we want to try to anticipate those at greatest risk and to try to treat those patients preemptively. So we always look at each case and we look at all the factors that are at play, and then those patients who we anticipate are going to have more high risk for having trouble with this, we might be more aggressive in our treatment recommendations and just empirically treat them even before they have symptoms. The other important thing is that you really need to educate patients about the symptoms and how to treat them if they were to happen. So we are very comprehensive in the educational materials that we give to the patients ahead of time, the day of surgery, and in a written form, so that when this happens, they know exactly what to do at home. And almost everybody can be very effectively managed at home if they have the right information. And the key is that oral treatment is by far the most effective. Many patients end up, getting sent to an emergency room because of a low calcium level and end up getting an IV of calcium. 1 gram of calcium through the IV really does almost nothing to really treat this problem, and it's just much more effective if we can treat this preemptively with oral supplementation. And the key is that we want to treat until the symptoms are gone. If you're having symptoms, it means that you still don't have enough. And unfortunately for many patients, this can require a lot of extra calcium for the first few days after surgery. So what happens when it gets really bad? Occasionally patients will have really severe hypocalcemia. Thankfully, this is relatively rare after parathyroid surgery, but it can happen. And in this scenario, we think of a couple things. One of the things is we always look at your other medications. If you're taking a medicine to reduce the acid production in your stomach, something like Prilosec, those really alter your calcium absorption. And so if you're on that, it's probably best to stop that so that you can get better absorption of the calcium supplements. The other thing we want to do is if you had vitamin D deficiency, that we want to make sure that we're treating that, because if you're vitamin D deficient, you're just that much less effective at absorbing calcium. We also may give you activated vitamin D in order to enhance the calcium absorption. If patients run chronically low magnesium levels, we may want to supplement that. So if somebody's refractory to our typical treatment regimens, we'll definitely make sure that the magnesium levels are checked and supplemented. So I always try to explain this, to patients, is that it's sort of like having a leaky bucket. If you're having trouble with low calcium after surgery, you've kind of got a bucket and it's got a slow leak on the bottom. And you can envision if you've got an empty bucket and it's got a leak, you put a little bit of fluid in it, and it comes right out the hole and you got an empty bucket again. So sometimes when you're having a lot of symptomatic hypocalcemia, it's like having an empty bucket. And really the best treatment is to fill the bucket. So if you take a fair amount of scheduled calcium, even beyond the point of no longer having symptoms, you can fill that bucket. And when the bucket's full and you have a slow leak, it's very easily maintained with a little bit of scheduled calcium. And you can really avoid the profound symptoms that sometimes patients can run into. So wound care after surgery. One of the things that we always recommend is ice. Ice is great for both pain control, and it can also reduce some of the swelling in the area. And also elevation. I think after surgery, having your head a little bit elevated or sitting upright can really reduce the amount of swelling. And the less swelling you have, the less pain you have. I think regarding the actual incision area, you really need to follow your doctor's wound instructions after surgery. There are a lot of different closures techniques that people use to try to get the best cosmetic outcome after parathyroid surgery. And so I didn't think you have to follow the instructions that your doctor gave based on the technique that they used to close it. After a couple of weeks, once the bandage is off and things have healed, it's completely appropriate to apply a moisturizer once a day. They sell a lot of scar reducing creams and special things. Honestly, anything that's good for skin is going to be good for healing. So if you put a moisturizer on it once a day, that's going to help give you the best scar outcome. If the scar area feels tight or you feel some tightness in your neck, you can massage the scar. What we typically say is put some moisturizer on it and rub along the length of the scar, and that can help break up some of the scar tissue underneath it and help speed the recovery of healing. It's really important to use sunscreen for the first year after surgery. Probably the one thing that can cause an unattractive scar outcome is if you get a lot of suntan or sunburn in the scar area for the first year. So we do recommend that you wear heavy-duty sunblock when you're outside for the first year. For some patients, they're prone to forming keloids or they'll have reddened, raised scars. And if that process is happening, one of the things that has been shown to help reduce that or improve scar outcomes is something called the silicone scar sheet. And those you can get at the pharmacy just over the counter. And it's basically a little pad made out of silicone that you can just put over the incision area. You can wear it just at night or you can wear it 24 hours a day, and it helps put some gentle pressure on the area and can help flatten the scar. And it's the one thing that's been shown in clinical trials to help improve long-term scar outcomes. So what do you do after surgery? What kind of supplements do you need to take? I would say we typically will recommend that all our patients do take some calcium supplements. When you have hyperparathyroidism, it's like a one-way exit of calcium from your body. So even though everyone's told you your calcium is high, it's too high in the wrong places. But your total body calcium levels are too low. You've lost a lot of calcium through having this disease. So we do want you to have that extra calcium. If you get it in your diet and you have a great, really healthy diet, maybe you get an adequate amount of calcium, that's great. But if you don't, then we do recommend getting some supplements in order to reach the daily recommended allowance, which is about 1,200 milligrams of calcium. You can get that through a couple different forms, either through your diet or through supplements. And the two major types of supplements that people have are calcium citrate and calcium carbonate. Calcium carbonate is by far the most common. That's what Tums is, Oscal, Biactive, those are all calcium carbonate. Calcium citrate is a different format, and it's typically, the most common one is Citracal. The format of these is that they have different side effect profiles. And so calcium carbonate is best if it's taken with food. You absorb it better when you have food. Calcium citrate can be taken on an empty stomach. Calcium carbonate is a little bit more prone to cause gas and constipation and bloating. And so for patients who are having GI side effects from it, it's better for them to take the calcium citrate. The problem with the calcium citrate is they tend to be bigger pills, and so patients are taking a little bit more of a horse pill. And so if you have trouble swallowing big pills, calcium citrate may not be the best option for you. Vitamin D supplementation is also important. Vitamin D deficiency is pretty much universally present in patients with hyperparathyroidism. And so we do recommend that patients be on some vitamin D supplementation after surgery. The daily recommended allowance of vitamin D is about 600 international units a day, but I would say that that's probably not high enough for most people. We're here in Wisconsin and we don't get enough natural sunlight, and so our vitamin D levels, I think, are all chronically low. So typically most of our patients in our region need at least 1,000 or 2,000 international units a day in order to keep their vitamin D in the normal range. Since many patients are deficient coming into surgery, if it's really deficient, it may be that just normal supplementation is just never going to get you to the normal range. So if our patients have significantly low vitamin D levels coming into surgery, we typically will do a short-term high-dose treatment, usually of about 50,000 units a couple times a week for a period of 4 to 6 weeks in order to get that supplemented. Once you're in the normal range, that maintenance dose of vitamin D can keep you there for the long term. So what should I do about my osteoporosis? A lot of patients with hyperparathyroidism unfortunately suffer from bone disease. And when that happens, surgery is by far the most effective thing you can do to help improve your bone density. And we typically recommend that you repeat your bone density scan about a year after surgery. Within the first year after surgery, we would typically expect to see somewhere between a 15 to 20% improvement in your bone density. So it's helpful to sort of see where that improvement is, how much improvement has been made, and whether or not additional therapy is necessary. Probably one of the most common questions I get is, should I stay on my bisphosphonate or Fosamax? Patients are already on those medications for the osteoporosis and they're wondering, should I stop these? I think the problem is we don't really know that answer. We've done some studies to try to address this question, and in our preliminary data, it looks like the benefit may be additive. You improve from surgery. We know whether you're on Fosamax or not, so you're going to get some benefit. But the patients who had surgery and also had the Fosamax probably had the greatest improvement. So I do think that they benefit you in different ways, and there may be some added benefit of doing both of those. So what I typically would say is if you're tolerating it well, then stay on it and reassess your bone density in a year and then decide at that point whether or not you should discontinue it or continue on that therapy. I think the other question that a lot of patients who have had surgery are is, am I cured? And I think, how do you know if you're cured? Your calcium should remain normal after surgery. We typically define cure as a normal calcium for at least 6 months after surgery. So it's great when the calcium is normal in the recovery room or a couple days after surgery. It's great when it's normal a couple weeks after surgery. But we don't officially mark you as being cured until we know at least 6 months after surgery that calcium is still where it needs to be. After 6 months, it's possible that the calcium could rebound back up into the abnormal range. The lifetime risk of that is about 2 to 3%. So we do recommend that once you've had this diagnosis that you have your calcium level checked on an annual basis. Parathyroid hormone level can also be elevated in some patients after successful surgery. And so it's a little bit harder to interpret the parathyroid hormone level after surgery. Sometimes that elevation is related to inadequate calcium supplements or low vitamin D levels. It may be related to some bone healing and recovery. Your bones are just hungry and they want extra calcium, and that's just a sign that we need to give you extra supplementation. I would say, however, that the best outcomes is if we can get both a calcium and a PTH in the normal level. And so it is always our goal to try to treat not only calcium but the PTH, and we'd like that to be normalized or normalizing by at least 6 months. Sometimes in the early postoperative period it's elevated, and it's simply elevated for these other reasons because the bones are hungry, the calcium or the vitamin D levels are still low, but we want to do everything we can to optimize that because I think patients get the best outcomes in the long term. They get the best symptomatic improvement and they get the best bone recovery if both of those are normal. So symptomatic low calcium is the most common problem after parathyroid surgery, and I think it can be effectively treated with the oral calcium supplements. You want to maintain normal calcium and vitamin D levels after surgery, and that's going to maximize your bone healing. We want to make sure that those bones have all the building blocks they need to restore your bone density. And then if you have osteoporosis, you want to repeat your bone density in 1 year, and then discuss with your doctor the need for additional therapy. And then I do think that you should have your calcium level checked annually because there is always a risk of developing recurrence, and the best way to detect that is to check labs. So I wanted to touch a little bit about kind of symptoms after parathyroid surgery. Patients always question, is parathyroid surgery going to make me feel any better? 10% of patients are officially labeled as symptomatic, and we typically think of symptomatic patients as those with kidney stones or fractures, and the remainder of the patients are often labeled asymptomatic. The reality is I don't think I've ever seen a patient who's asymptomatic with hyperparathyroidism, and I think anybody who says the word asymptomatic hasn't really talked to their patients. My patients have a lot of symptoms. I just think sometimes people aren't really asking the right questions. And when we did this in a survey, we found that really asymptomatic hyperparathyroidism doesn't really exist. And over 95% of patients really do have significant symptoms that are likely related to their disease. We did a survey of patients where we asked them to grade the severity of symptoms, and what we found is that the average number of symptoms that a patient had was 11, and that 96% of patients complained of fatigue at some level. So symptoms are actually fairly common. It's just that patients aren't asking. So why aren't we recognizing the symptoms sooner? I think the symptoms are fairly nonspecific and they're difficult to quantify. We write them off for other reasons, both we as doctors and you as patients. I think, primary hyperparathyroidism is unfortunately like premature aging. The symptoms are what you expect to happen with older age. It just happens sooner than you think it should. And that can be really frustrating, and I think that often leads to a lot of misdiagnoses. So what causes them? We think it's related to either the excess calcium or the excess parathyroid, or some of those symptoms, probably a combination. However, the symptoms of parathyroidism do not correlate with your labs. So the higher labs does not necessarily mean that you're going to have more symptoms. And some of the most symptomatic patients that we have very mild lab abnormalities. And I think that that's something we as surgeons see all the time. So will the symptoms get better after surgery? I think the answer is yes. 60 to 70% of symptoms improve. That means a lot of patients notice significant improvements after surgery, but it's not 100%. I wish it was 100%. And unfortunately, we can't always predict which symptoms are going to get better and which ones are not. So I think there's a good chance that you'd notice symptomatic improvement, but I can't guarantee that everything's going to get better. What is the time course to improvement? It varies. Things like bone pain, I think, are clearly parathyroid hormone mediated. Those are typically gone in the recovery room. Energy, people typically will notice improvements within the first 2 to 6 weeks after surgery. And things like memory, I think, are more chronic changes, tend to take longer, and people will notice continued improvements up to 6 months or a year after surgery. What other health impacts will surgery have on my health? Symptoms improve. Patients just feel better. Your bone density improves, and it lowers the rate of fractures. The other thing that we have found is that it can lower your risk of heart attack, and patients can just live longer. I want to make sure that we save some time for questions, so I'm just going to skip over a couple of these other slides that we're just going to talk about the bone density. I think that while many patients are discovered incidentally, the majority are actually quite symptomatic, and virtually all patients with hyperparathyroidism will benefit from parathyroidectomy, whether that be symptomatically, metabolically, or just improved survival. I put on here, I know that there's probably a lot of questions that we didn't cover in today's talk. I wanted to give you some web resources which I think are really valuable. The American Association of Endocrine Surgeons did a pretty comprehensive effort a couple years ago to put together this patient education website called endocrinediseases.org, and I think it has a lot of really helpful information to help guide patients. And so if you're looking for information, that's a great resource. The other thing is on our UW website, we have tried to put a lot of the information that we're talking about today, and that can be a great resource if you're looking for questions. All right, so at this point, we're going to take some time to answer some of the questions. We have both the list that you guys submitted in advance as well as some of the ones that have come in during the webinar. And so I think we have some microphones around the room, so I'm hoping that you'll be able to hear us wherever we're at, but we'll go ahead and start answering some of those questions. So I'll turn it over to Dr. Schneider first. Dr. Schneider, do you want to answer one of the questions that you received?
Sure. Somebody asked, I mentioned the computer program that we've developed here, and somebody asked how long that has been available and how many doctors are currently using it. We've really just developed it in the last year, and we're right now in the process of submitting it for publication. I think after that, we need to do some more testing of it before we just release it as, a tool that everyone should use. But we are developing an app, and we hope to put it on our website so that physicians can have access to it and use it more as a second opinion right now. And as we refine it and develop it, then hopefully we can really increase the number of physicians that have access to it. Ultimately, we hope to integrate it into electronic medical record systems so that physicians can be automatically alerted when somebody's labs are consistent with the disease.
Great. How about Dr. P? Questions?
Yeah, I'm actually going to discuss two of them. They were both related to secondary hyperparathyroidism related to vitamin D deficiency. And one of the questions has to do with, prescribing these megadoses of vitamin D to kind of disprove that there's any actual primary hyperparathyroidism, and kind of can we explain the protocol. And then the other is just how much supplementation is needed and for how long. When someone is vitamin D deficient prior to surgery, there's obviously degrees of vitamin D deficiency. And so patients who have severe vitamin D deficiency will get much different treatment than patients who have mild vitamin D deficiency. And so it's hard to say, that there's one particular protocol or one particular way to supplement the vitamin D or how long to do it. It's really looking at each patient, making sure that the vitamin D levels are coming up and checking them over time to make sure that they're normalizing before you can conclude that somebody has primary hyperparathyroidism and completely rule out secondary disease.
Great. So I'm going to take on one of the questions that just came in was, does parathyroid disease affect the function of the thyroid? And I think this is a very common question that patients have because the names are so familiar. Everybody knows about the thyroid gland, but nobody's ever heard about the parathyroid gland until they're told they have a problem with it. The parathyroid glands, even though they're directly related to the thyroid right next to it, anatomically, their function really is not interrelated at all. That being said, is when we take out the parathyroids, a lot of times we're pushing on the thyroid gland or sort of moving it out of the way. So there probably is a little bit of extra release of thyroid hormone at the time of parathyroid surgery, which typically would last no longer than 5 to 7 days after surgery. But really beyond that period, there shouldn't be any long-term effect on thyroid function. Occasionally, when patients have a parathyroid gland, it can be contained inside the thyroid, or the thyroid has to be mobilized in order to remove the parathyroid. And in those cases, it's possible that some of the thyroid could be removed. And so if anything has been done to your thyroid in order to remove the parathyroids, it's reasonable to check your thyroid function. But beyond that, there really shouldn't be any impact of parathyroid disease on the function of your thyroid. All right, Dave, do you have?
Sure. Somebody else asked, what if you had a failed parathyroid surgery and have had 2 sestamibi scans, 1 SPECT scan, 1 ultrasound, a 4D CT scan, and you still can't find your missing parathyroid? What is the next step? Well, all hope is not lost. I think what we would do here is kind of look at everything from the beginning. So we'd want to look at your labs right now. We'd want to look at what was done during your surgery where they couldn't find it, where they looked, what they saw, what was sent to pathology, what the pathology results were. And then we'd look at all of these scans that you said that you've had done. As I mentioned in my talk, a lot of the times they were read as negative, but we look at them and we can clearly see where the parathyroid is. We also do our own ultrasound when we see patients in clinic. Oftentimes, parathyroids aren't seen on ultrasound because the person doing the ultrasound doesn't even know where to look for them or where they could be hiding. And so it's not uncommon that I will do an ultrasound on a patient like you and see it very clearly. If, let's say, all of these scans are indeed negative or non-localizing, then there are other more advanced techniques we can use, like venous sampling or angiography, or selective use of MRIs, or maybe even repeating some of the 4-dimensional CT scans that you've had, and often we can localize it there. So I would say this doesn't mean that you can never be treated, and it doesn't mean that you can't be cured.
One of the other questions that we received that can be a little bit related to this and has to do with imaging is there any reason that some parathyroid glands don't necessarily show up on scans or other imaging? And this, like Dr. Schneider just said, has a lot to do with the technique and experience of the person who's both performing the scan, if it's an ultrasound, or reading a scan. For sestamibi scans, I discussed earlier how the mitochondria uptake the sestamibi, and so if you have a small gland that's perhaps at a posterior location or someplace that's difficult to see, you may not see it. And then also, if for patients who have hyperplasia or foregland disease, their parathyroids are not always very enlarged, and so typically those patients will have negative sestamibi scanning. Lastly, if you're getting a 4D CT, if the phases of the CT scan aren't right with contrast, the benefits of performing the 4-dimensional CT scan are lost. And in those cases, your parathyroids can look like lymph nodes or not be very discernible from other surrounding tissue.
All right, so I had a question come in about what is the difference between an enlarged parathyroid gland and parathyroid hyperplasia, and if so, what's the difference? And I think that this is a thing, when we talk about a parathyroid adenoma, what that typically is, it's a normal parathyroid gland that then has an attached adenoma or a growth that's very distinct. And that when we see that, we typically assume that that's a single gland problem. Occasionally people can have double adenomas, but we don't typically worry about that being all 4 glands. Hyperplasia means that the gland itself is just diffusely bigger than it should be. And that's a hyperplasia is what we would see in vitamin D deficiency. It's what we see in patients who have kidney failure. And it's what we see in about 20% of patients who have primary hyperparathyroidism, where just all 4 glands are bigger than they should be. And they don't have this discrete adenoma coming off of the gland. So really, I think the judgment of whether it's an adenoma or hyperplasia is based on the surgeon judgment and finding at the time of surgery. The pathologist may or may not make this distinction on the pathology report, but it really just depends on how carefully they look at it. They may only do one section of the parathyroid, and if they don't happen to capture the normal gland adjacent to the adenoma, they may just call it hyperplastic, but in reality it probably was an adenoma. So my approach is when I remove a gland is I always examine it and I carefully look at it. And if I can see the normal gland attached to it, then I know that it's a true parathyroid adenoma, and that's how I'll classify it. But I don't think pathology reports are very reliable. So I wouldn't worry at all about what your pathology report says, because I think that that probably isn't the best way to distinguish it. It's more what your surgeon saw at the time of surgery.
We have 5 minutes left, so maybe just 1 or 2 more questions and then we'll wrap it up.
Sure. Dr. Schneider and Dr. Pitt, do you have another question?
Sure. Somebody's asking here about they had parathyroid surgery, and the calcium and PTH numbers are good, which is excellent, but the vitamin D level was slightly low. And her doctors or his doctors have supplemented with 1,000 to 2,000 international units. Is this usual for someone after surgery for primary hyperpara? Well, that's a great question. We see this all the time, and as Dr. Sippel mentioned, vitamin D deficiency is very common, and it's actually very common among patients that have parathyroid disease. So after you've been successfully treated, it's really important to replete your body stores of vitamin D. The way that we typically do that is by giving patients a short course of ergocalciferol and then rechecking the labs. So the vitamin D pills that you can buy over the counter are vitamin D3, which really isn't the same as ergocalciferol, and it's a lot quicker and easier to replete your total body vitamin D by taking a short course of ergocalciferol and then checking the labs again.
All right, so then the one last question, one of the questions was somebody said, after surgery, the symptoms didn't go away. And in fact, they think some of the symptoms may have gotten worse. And is that a common problem? And I think that, as I mentioned, symptomatic improvement is seen for a lot of patients. And for many patients, it's a very dramatic improvement after surgery, which is wonderful. And I wish that that was the outcome that everybody had after surgery. Unfortunately, for some patients, the symptoms don't get better. And what that means when they don't get better is that they probably weren't caused by the hyperparathyroidism. That there's symptoms that we see in hyperparathyroidism, but in that case, they weren't caused by it. That doesn't mean that you didn't perceive benefits from having your hyperparathyroidism fixed, though. Still, even if you still have some of the symptoms that you had before, your bones are definitely going to improve. You're decreasing your risk of kidney stones. You're improving your kidney function in the long term. You're decreasing your risk of heart attack and stroke, and you're improving your life expectancy. So even if you don't feel any different, your body is definitely perceiving the benefits of surgery in other ways. And so I do think that it's definitely still a worthwhile thing to treat. All right, I think that we're coming to the end of our time, and so I appreciate all of you coming in and participating in this, and we hope that this was a valuable format for you. We are going to be recording this and posting it on our website and I think on our Facebook page, so it'll be available for you guys to participate and continue to watch. We want to thank you again all for participating and for your participation in this. Please send us any feedback or things that we can do and how we can help support your group in the future.
Sorry for the technical difficulties. It was our first webinar. I understand that Dr. Schneider's slides were not viewable in the beginning, so we really apologize. If we do this in the future, definitely we'll get those glitches worked out. But thank you, Dr. Pitt, Dr. Schneider, and Dr. Sippel for sharing your time and expertise with us. Thanks everyone for your participation this evening. We look forward to having you join us for future programs. Thank you, everyone, and good night.